Hi, thanks, Bhavika. Our final keynote speaker is Dr. Sanjeev Phatak. He is affiliated with Oxford Diabetes Centre, Steno Diabetes Centre, and Jocelyn's Diabetes Centre. He is a practicing diabetologist and physician at Vijayaratna Diabetes Diagnosis and Treatment Centre and Thakurshi Charitable Trust Hospital. He is the principal investigator in over 30 global clinical trials, including the new CVOT trials. He has been invited as guest faculty at various national and international level of conference, including SAARC, RSSDI, APICON, Diabetes India, and CID. He has several publications as first author and co-author, including publications in Diabetes Care, International Journal of Diabetes in Developing Countries, Journal of Clinical Diabetology, and JAPI. He was the recipient of Sanofi Lectureship Award at APICON in 2016 and a life member of APA, API, RSSDI, IDF, ADA, and AACE. He is also the ex-president of Association of Physicians of Ahmedabad and the current director of Juvenile Diabetes Association Ahmedabad. He was the first diabetologist in India to start insulin pump therapy. He has developed and published unique diabetes motivational health score in the year 2018. If you have any questions during this session, please write them in the chat box. And now, please welcome Dr. Sanjeev Phatak.
Good evening. Thank you, Anjali, for your very generous introduction. And Anjali being as good as my daughter, or rather I can say as bad as my daughter. Thank you, Dhruvam. Thank you, the AMCON team, for giving me an opportunity to share my views about managing a newly diagnosed type 2 diabetes patient. Anjali, may I have the opportunity to share my screen? So can I share my screen now?
Yeah, please go ahead.
Sure. So is my screen visible now?
Yeah.
Can you see my screen?
Yeah, it's visible.
Yeah, okay. So I'll be talking about how to manage a newly diagnosed type 2 diabetic patient, right? Managing a newly diagnosed type 2 diabetic patient is as complex as you see on the right side of the slide, the complexity which is involved in this. Meaning thereby that it is not now in the world of so many medications so easy to manage type 2 diabetes unless you have understood it very well. And that's what I'm going to do in next 30-45 minutes. Well, my presentation will comprise of some important cases which are not very how to manage them in the practice and what do the guidelines say. And then the blue index, which we published a couple of years ago, I'll be just touching upon that. One important aspect I'll be touching upon is the reversal of diabetes. Is it possible? And finally, in the COVID era, how does management of diabetes change? That we will discuss in final slides. So all the pictures I will show in this presentation are imaginary. Any resemblance to any character, living or dead, is purely coincidental. So please bear. So I'll start with case number 1. A 40-year-old male comes to you with fasting blood glucose of 120. He is not having any symptoms. He is asymptomatic. His father had diabetes and he had died at a young age of 65 of myocardial infarction. I say 65 as young because these days people live quite long. His weight is 95 kg, which according to his height, his BMI becomes about 30. So how will you manage? Can anyone have the answer in the chat box? I'll wait for 30 seconds and then I'll proceed. So what diagnosis do we have for him? Does he have diabetes? How many say yes? How many say no? And how many say that can't say right now? So what are the diagnostic criteria for diabetes? Well, we'll close the poll and we'll look at the chat box later on. Well, according to the American Diabetes Association 1997 and WHO 1999, the criteria have been almost same thereafter, which means if fasting is more than 126, Fasting means fasting for 8 hours, and that is overnight fasting. Or casual plasma glucose, or what we call popularly RBS, more than 200 milligram in presence of symptoms, or our post glucose, not post meals, because meal cannot be standardized. Someone may be eating 3 rotis, someone may be eating 5 rotis. So meal cannot be standardized. So it is 2 hour post 75 gram glucose more than 200. So any of these criteria, if patient has, he is classified to have diabetes. And this is true for type 1 as well as type 2. But in type 1, you don't require this criteria because type 1 diabetics present with very high sugar straight away. I'm not going to discuss about type 1 diabetes today. We are going to discuss about mainly type 2 because in our Indian population, 95% of the diabetes is type 2 diabetes. So coming back to this case, what other investigations are required? Well, fasting was 120. According to the ADA or WHO criteria, more than 126 is diabetes, less than 100 is normal. So he falls between normal and abnormal. So you can say from fasting, he has prediabetes or impaired fasting glucose. And that is why we will require either an oral glucose tolerance test or an HbA1c, right? So whether HbA1c is having any diagnostic value, 5 years back, HbA1c was not considered in the diagnosis of diabetes. But of late, the guidelines have been revised and have included HbA1c also in the diagnosis of diabetes. So if HbA1c is less than 5.7, it is normal. 5.8 to 6.4, it is prediabetes or a person at risk of developing diabetes. And more than 6.5 or 6.5 itself, both inclusive, is diabetes. So we need to get his HbA1c done to know whether he is having diabetes or not. Suppose his HbA1c is 6.2. Then we would classify him to be having prediabetes. But the important message is that in spite of being prediabetic, he is at risk of developing cardiovascular disease because he is overweight, he is having strong family history of coronary artery disease, and that is why we need to treat him as aggressively as we would do in a diabetes patient. We need to control his blood pressure, we need to control his lipids, and we also need to look at his uric acid and SGPT. Dr. Hitesh Chawda in his presentation might have referred to fatty liver disease as one of the important liver diseases these days. And the commonest cause of fatty liver disease is metabolic syndrome or diabetes itself. Even for cirrhosis, alcohol has become the second most important cause. The highest incidence of, the highest prevalence of fatty liver disease is found in patients, or cirrhosis also is found in patients with obesity or type 2 diabetes or metabolic syndrome. An ECG may also be required, or a TMT and coronary calcium to rule out whether he is having asymptomatic cardiovascular disease. We'll not discuss about that here. Let us have a look at what is metabolic syndrome. So metabolic syndrome is defined as central obesity or waist circumference more than 90 centimeter in males or 85 centimeter in females. Hypertension, that is systolic more than 140 and diastolic more than 90. IFG, IGT or diabetes. So not necessarily diabetes. Even if patient with pre-diabetes, if he is obese, he is having hypertension, then he fits into the criteria of metabolic syndrome. And dyslipidemia in the form of high triglyceride more than 150 or HDL less than 35. For our Indian patients, sometimes LDL may not be that high. We are having atherogenic dyslipidemia. We are thin fat Indians, which means even at low BMI, we are having more visceral fat. And that is why we are having more insulin resistance. And that's why treating our Indian patients aggressively early on is the key to prevent the late diabetes complications. So the message from the first case is that even if he is pre-diabetic, we need to emphasize on diet, exercise, and if required, pharmacotherapy also, because now we know that metformin and some other drugs are also recommended even at the pre-diabetes level. We'll move on to the case number 2. 50-year-old gentleman recently diagnosed to have diabetes. His weight is 85, his BMI is 30 again. His fasting is 145, his postprandial is 230, and his HbA1c is 7. Sorry. The doctor advised him diet and exercise and no need to start OAD and asked for no further tests. Doctor told him that abhi chalega, abhi diet or exercise karo, 3-4 mahine ke baad dekhenge, and then if required, we'll go for the medical therapy or pharmacotherapy. Was he right? Well, 15 years ago, these were the guidelines that start with diet and exercise. If target is not achieved, then you start the therapy. But over a period of time, all the international studies have shown that it is a failure-based approach and that should not be acceptable, because what happens with that patient lands up into multiple complications later on because you are not treated the disease early on. This patient, since he was not treated, got hospitalized with heart attack 6 months later. Could this have been prevented? Yes, definitely. Had we started treatment early on, not only diabetes treatment, but the other things also, probably this could have been prevented. So let us come back to this case. His BMI is 30. His blood pressure is 145/95. He is a smoker. So now, how will you manage? So I'll give you 1 minute, rather half a minute, and you can put in the chat box that what treatment will you suggest to this patient? His HbA1c is 7. Okay. Well, the common answer may be diet, exercise, and oral anti-diabetic monotherapy, right? But before that, we must find out what are other abnormalities, because as we discussed earlier, that type 2 diabetes is as a result of insulin resistance. And this patient may have abnormality of the lipids. He may have elevated creatinine, and we must calculate the GFR also, because according to the United Kingdom prospective diabetes study, which was done about 20 years back, had shown that even at the time of diagnosis, about 25% of our patients do have renal complication or diabetic nephropathy, which is undetected. And unless you go for creatinine and urine microalbumin test, you may not be able to detect this. And if not detected in time, it may lead to renal failure and, more importantly, cardiovascular problem. Any patient with renal problem is at more risk of dying due to the cardiac cause rather than renal cause itself. Moreover, as we discussed, patients should also be advised to undergo an SGPT test, which is a simple blood test. Hemoglobin obviously will be required. Baseline ECG, resting ECG is also necessary. And at the same time, retinal examination, because 15 to 20% of our diabetic patients, again at diagnosis, have diabetic retinopathy also. The reason being that in our country, diabetes is detected quite late, and that's why number of times type 2 diabetic patients come to us with multiple complications. They were never knowing that they were having diabetes unless they come to know after they have some visual problem or their creatinine is elevated or they develop some cardiac problem. So coming back again to this case, what are the treatment options? Of course, one option, which was correct maybe 15, 20 years back, was only lifestyle changes, total lifestyle changes. There is diet, exercise, and avoidance of stress, avoidance of smoking, and all that is in the lifestyle changes. But we now know that it is not sufficient, and that is why the guidelines now recommend to start with metformin right at the time of diagnosis, along with diet and exercise. But in the next few slides, I'll show you that why still guidelines recommend only metformin, which actually is not appropriate for our Indian Asian patients, and we should go for lifestyle plus oral combination therapy straight away. And what else? Apart from diet, exercise, oral therapy of anti-diabetic drugs, anything else is required, we'll discuss over a bit of time. There are different guidelines for managing or guiding you regarding the management of type 2 diabetes. American Diabetes Association guidelines, Joslin guidelines, IDF guidelines, EASD guidelines, and our own Research Society of Study in Diabetes in India, RSSDI guidelines. Amongst all these guidelines, the American Diabetes Association guidelines are accepted mostly across the world. What do they say? This is 2020 guidance of ADA, which shows that diabetic patients are at high cardiovascular risk, and if they are having high cardiovascular risk or having cardiovascular disease already established, we should consider agents with cardiovascular disease benefit independently of the baseline HbA1c. So the first line therapy will be metformin along with comprehensive lifestyle changes. But if patient is having high cardiovascular risk or is having established cardiovascular disease or chronic kidney diseases or heart failure, we should also add along with metformin either an SGLT2 inhibitor, which are new class of agents, or a GLP-1 analog. We'll discuss what are they in subsequent slides. If patient has atherosclerotic vascular disease, GLP-1 with proven benefits are preferable. If patient has heart failure or CKD, then SGLT2 is preferable. If one class is not tolerated or is not adequate, then the other class can be added. On the other hand, if patient does not have any established cardiovascular or renal disease, and if the HbA1c is above normal after 3 months of metformin therapy, we have option of adding a DPP4 inhibitor or a GLP-1 analog or an SGLT2 inhibitor or a pioglitazone, that is thiazolidinediones. If patient comes to you with significantly high blood sugar, then obviously the option of insulin is always there. In our country, when cost is a major issue, we can even consider sulfonylurea or pioglitazone, which are cheaper drugs. But now, fortunately, the DPP4 inhibitors and the SGLT2 inhibitors have also become cheap, so as we can give the benefit of these important therapies to our non-affording patients also. Some of the agents promote weight, some of the agents cause weight loss, and for that, GLP-1 analog and SGLT2, they cause weight loss, which is very important in our type 2 diabetic patients who are either generalized obese or are having central obesity in form of increased abdominal girth. Another popular guideline is the American Association of Clinical Endocrinology algorithm, ACE algorithm. It suggests you treatment based upon the initial or entry-level HbA1c. If the entry-level HbA1c is less than 6.5, then you should start pre-diabetes algorithm. If it is more than 6.5, you should start the diabetes algorithm. If it is between 6.5 and 7.5, according to the ACE algorithm, the monotherapy may suffice. That means either metformin or any of these drugs. And this is the suggested hierarchy of treatment, GLP-1, SGLT2, DPP4, pioglitazone, like that. If the entry-level HbA1c is 7.5 to 9, then most probably this patient will not have control with monotherapy and they will require dual therapy. That is metformin plus a GLP-1 or SGLT2 or DPP4. These are having more evidence right now compared to pioglitazone and sulfonylurea, where there are some safety issues. Of course, metformin will remain as background therapy in all these patients. If the entry-level HbA1c is more than 9%, and if patient is asymptomatic or having minimal symptoms, then maybe dual therapy or even triple therapy to start with may be required. Triple therapy means metformin plus two other agents, two other oral agents. But if patient is symptomatic with HbA1c of more than 9 or 10, symptomatic means he may be having polyuria, polyphagia, polydipsia, weight loss, osmotic symptoms, genital infections. These are the symptoms which suggest that there is significant hyperglycemia and patient is having insulin deficiency at least at that point of time. And these patients are better treated initially with insulin plus or minus other agents. Later on in these patients, if they are type 2 diabetic patients, if they are having enough insulin production, after correction of the glucotoxicity, we can switch them to the oral anti-diabetic drugs. So to simplify, less than 7.5, monotherapy 7.5 to 9, dual therapy more than 9, asymptomatic triple therapy more than 9, symptomatic insulin plus other oral agents. And this is what the ACE algorithm is all about. Discuss some of the important drugs that we use to treat type 2 diabetes. Metformin being the basic drug. We always say that metformin is a horse which is required in all the races and it will run throughout the race. The jockeys will change, and the jockeys we have are SGLT2, GLP1, sulfonylurea, DPP4, different jockeys are there. Metformin is having enough evidence now for last 25 years after UKPDS. You may be surprised that before UKPDS trial was published, this drug was banned in USA because of the possible risk of lactic acidosis, which no longer is considered a risk now unless patient is having significant renal insufficiency. Having said that, metformin is contraindicated if the GFR is less than 30 or when patient is having acute illness, like patient is hospitalized for any fever or any acute emergency, including COVID. It has some beneficial effect on the atherosclerotic vascular disease, but is neutral as far as the heart failure or the kidney disease is concerned. And the major side effect of metformin is gastrointestinal side effect, especially diarrhea. And there is potential for B12 deficiency also. Any patient on metformin, if he has neuropathic symptoms, we should remember that B12 deficiency may be there, so we need to take care of that. The second important class of agents are the SGLT2 inhibitors, which are relatively new in practice for last 5 years. But in last 5 years, they have shown with several cardiovascular and renal trials that they are very effective not only in lowering the glucose, lowering the HbA1c, but also in reducing blood pressure, improving the lipid parameters, reducing the weight, especially the visceral obesity, and in reducing the cardiovascular complications, especially heart failure, as well as delaying the progression of the diabetic kidney disease. No other agent in past has shown so much benefit in addition to glucose control. All other agents till now have shown only reduction of the HbA1c, but SGLT2 inhibitors are the first class of agents where there is enough evidence with several trials, whether it is with empagliflozin, canagliflozin, or dapagliflozin. I will not discuss the different trials here, but they are having enough evidence that they have significantly reduced risk of development of cardiovascular disease as well as the renal disease. The drawback is that they cannot be used if the GFR is less than 30 or 25 because they work through kidneys. Not that they will harm kidney, but they will become less effective because their action is through the renal tubules. Moreover, there are some other risks also, and the main risk is the genitourinary infection because these drugs work through excreting glucose through urine. There is about 70 to 80 gram of glucose loss per day, that is equivalent to 320 calories per day. But due to that glucose loss in urine, patients are susceptible to genitourinary infection, balanitis in male, and vaginal candidiasis in female. So unless you have explained proper hygiene to the patient, this drug may become burdensome because of this side effect. Moreover, they also cause significant diuresis, and that's why there is some risk of volume depression, which should be taken care of. Some other side effects include euglycemic ketosis, but if judiciously used, they are very good drugs to start with, along with metformin in type 2 diabetic patients. The third agents which we will discuss here are GLP-1 analogs. And in our country, liraglutide, dulaglutide, these two are available. Soon, semaglutide will be available in oral form. right now the injectable GLP-1 which are available is liraglutide and dulaglutide. Liraglutide is once a day, dulaglutide is just once a week. The advantage of these agents are that they can cause weight loss and they are also having cardio-renal benefit. Major problems are they are having significant gastrointestinal side effect in form of nausea, vomiting, sometimes diarrhea. They are injectable drugs and there is some risk of acute pancreatitis. Of course, this risk is not seen in the clinical trials. Moreover, they are quite expensive and may cost about 10,000 rupees a month, which is beyond reach of many of our patients. The other drugs that are used are DPP-4 inhibitors, or popularly known as gliptins, where we have sitagliptin, linagliptin, teneligliptin, vildagliptin, and some other gliptins. These are effective, but not as effective as GLP-1 and SGLT2. They can reduce HbA1c by about 0.7 to 1%. The benefit of DPP-4 inhibitor is they are absolutely safe drugs. They do not have any major side effects. They are very safe as far as management of type 2 diabetes is concerned. But there is no cardiac or renal benefit associated with that. But at the same time, they do not harm the heart as well as kidney and can be used even with advanced kidney disease. Then comes the alpha glucosidase inhibitors, that is acarbose and voglibose. They are good drugs, but they reduce only the postprandial hyperglycemia. They do not have any effect on the fasting glucose. The major side effect is gastrointestinal, flatulence, sometimes diarrhea, otherwise they are also safe drugs. Then comes pioglitazone, which is a controversial drug, but quite effective and actually is having atherosclerotic vascular disease benefit. But the problem is it can cause salt water retention, weight gain, and can precipitate heart failure also because of the salt water retention properties. The drug was in debate due to bladder cancer controversy, but that has now been removed. Especially in India, the risk of bladder cancer with pioglitazone is absolutely low. Sulfonylureas still remain the popular drugs. Glimepiride, gliclazide, glipizide, glibenclamide. They are potent drugs, but the only problem with them is they can cause sometimes severe hypo, especially if patient has not taken proper meal. And they also cause some weight gain. They are having no cardiovascular benefit, but they are neutral as far as the cardiovascular risk is concerned. Untested molecules, they are otherwise safe except for the risk of hypoglycemia. So when patient has mild hyperglycemia, it is better to avoid sulfonylurea. The other class of agents till now I discussed do not cause hypoglycemia. I would say that they are anti-hyperglycemic drugs, whereas sulfonylureas can cause hypoglycemia. And finally, insulin. And insulin, we have short-acting or rapid-acting insulins, intermediate-acting insulins, premix insulin, and long-acting insulins as well. I'll not go into details about insulin. Whichever algorithm you like, one should follow them, either ACE algorithm or AD algorithm. And even ACE algorithm suggests that even at pre-diabetes, we should start some form of therapy. Moreover, in addition to treating glycemia, in every diabetic patient, we must assess their cardiovascular risk. And if the cardiovascular risk is significant, we must treat their dyslipidemia also with statin. If triglyceride remains more than 500 in spite of statin, then fibrate may be added or omega-3 fatty acid. We also need to treat hypertension with either ACE or ARB to start with, and then maybe calcium channel blocker, beta blocker, thiazide, or whatever therapy is required. So A, B, C, all three things have to be treated. A is A1C, B is blood pressure, C is cholesterol. If you really want a comprehensive control of type 2 diabetes in reducing the complications. You may be aware about the ominous octet described by DeFronzo in 2009 in diabetes, which means that previously, and the conventional teaching has been that diabetes results due to two basic defects. One is insulin resistance, second is insulin secretion. Yes, of course, these two defects are still basic. But in addition to that, there are other factors also, which is known as the ominous octet. Number one is, of course, the insulin resistance, leading to increase in lipolysis, decreased glucose uptake at the muscle level, and increased hepatic glucose output from the liver. Then there is beta cell effect, resulting into decreased insulin secretion. But at the same time, in type 2 diabetes, there is alpha cell defect. Beta cells secrete less insulin, but in turn, alpha cell, maybe due to paracrine effect or whatever, starts secreting more glucagon, and that also leads to hyperglycemia. Moreover, kidneys actually should be throwing away more glucose in diabetes. But unfortunately, in type 2 diabetic patients, kidneys threshold goes up and they cannot excrete glucose to the extent that they actually should be excreting. And that is why kidneys actually try and preserve more glucose, leading to hyperglycemia again. Moreover, there is neurotransmitter dysfunction also, which means that the brain also plays a central role in causation as well as in the precipitation of hyperglycemia. And finally, there is decrease in incretin effect. That means if you give glucose orally from intestine, the intestinal L cells will secrete GLP-1, which would in turn stimulate insulin secretion. But that does not happen in diabetes patient to a magnitude that it would happen in a non-diabetic, which is called incretin defect. So diabetes results as a combination of this. Unfortunately, the guidelines suggest that you should start only metformin when HbA1c is in the range of 7. And we'll come back to this case again, that when HbA1c is 7, what therapy should be given. So guidelines suggest that start only with metformin, but unfortunately, metformin works only on the liver. So if you look at this ominous octet, metformin works only at this one level, that is increased hepatic glucose output. Metformin does not have any effect of any on any of this. So even if metformin may be effective initially, over a period of time, its effect will wane and patient may experience hyperglycemia, leading to complications. So the current concept is that start something along with metformin so that not only glucose is taken care of, but the pathophysiology of the disease is also taken care of. And this is how we treat all the diseases. How do we treat pneumonia? We don't treat fever. We don't treat cough. We treat the root cause. Of course, the root cause is bacteria. Of course, these days, in the COVID era, root cause has changed from bacteria to virus. But I mean to say that any disease, we should be treating not the numbers, not just the HbA1c, but we should be treating the underlying pathophysiology of the disease. And the pathophysiology of the diabetes lies in these 8 factors. And that's why, right from the beginning, we should be taking care of most of these etiological factors, most of these pathogenetic factors which cause diabetes. And if you treat them well, probably you will have a long-term diabetes control. Second reason for not starting metformin alone is metformin is a good drug for fasting hyperglycemia. Early on in type 2 diabetes, especially when HbA1c is in the range of 7, 7.5, postprandial contributes very significantly to the HbA1c. And metformin, being a drug for fasting, may not be very good for postprandial hyperglycemia. So in spite of giving metformin, your fasting may come down, but postprandial may not come down, and you may experience less than expected HbA1c reduction. So for reducing postprandial, we need an agent which will take care of postprandial also. The most effective strategy in reducing the postprandial for our Indian patients is restriction of the carbohydrate. Whatever we take in our diet, maybe from breakfast to dinner, contains carbohydrate, carbohydrate, and carbohydrate. Whether you are staying in West or whether you are staying in North or South, anywhere in India, our diet, right from breakfast to dinner, is only carbohydrate. If you are in Punjab, you may be eating aloo paratha. If you are in Bengal, you may be eating a lot of rice. If you are in Chennai, you may be eating idli. And if you are in Ahmedabad, you may be eating khakra. And if you are a little bit westernized, then you may be eating cereals or breads. all of these are carbohydrates. So we must remember that the first important thing which we should do in type 2 diabetes management is restriction of carbohydrate, especially the simple carbohydrate, and restriction of fat. Along with that, exercise also plays a very important role. We'll not discuss that because of the paucity of time here. But if you look at the natural history of diabetes also, diabetes begins postprandially and progresses postprandially. And by giving metformin alone, you will target fasting and postprandial may be missed. And that's why patient may have less desirable glycemic control. Moreover, diabetes is not just a disease of blood sugar, it is a disease of cardiovascular system. It is a disease of renal system. So right from day one, our aim should be to reduce or prevent the chances of cardiovascular and renal complications. Since 2008, US FDA has mandated cardiovascular safety for any agent. And metformin has cardiovascular safety but not benefit. The benefit is shown only in the UK PDS trials. Subsequent trials have not shown. Whereas the GLP-1 analogs as well as the SGLT2 inhibitors have shown significant cardiovascular benefit. Again, I will not go into details of this slide, especially heart failure, because the risk of heart failure is also very high in type 2 diabetes patients. And all this study, including AMCON, CANVAS, DECLARE-TIMI, CREDENCE, have shown that SGLT2 inhibitors reduce the risk of heart failure by about 30 to 40%. So we should be using them early in the disease. Of course, having said that, we must take care of the genitourinary part or the infection part of these patients. Comparing SGLT2 and GLP-1, both are having cardiovascular benefit, but the benefit of SGLT2 starts much earlier than compared to the GLP-1 analog. And again, they are oral therapy, much less expensive and well tolerated compared to the GLP-1 analogs. Several trials, including AMCON, CANVAS, have shown its cardiovascular benefit as well as the renal benefit. So coming back to this case, what should we start? Now I think the verdict is clear. We should start with lifestyle plus oral anti-diabetic therapy combination. The ideal in this patient may be metformin plus SGLT2 because this patient is overweight, is having cardiovascular family history, and maybe having some other cardiovascular risk factors also. If patient is not able to afford or tolerate SGLT2, then one can consider metformin plus a DPP4 inhibitor. Since his HbA1c is only 7, giving him sulfonylurea may increase the risk of hypoglycemia. So at this point of time, we should be avoiding the drugs that cause hypoglycemia, and we should be using the drugs that are devoid of that side effect. So all these are devoid of that side effect. GLP-1, of course, probably the topmost agents amongst all this, but as I said, it is injectable, quite expensive, and is associated with gastrointestinal side effects. And that's why the overall acceptance and adherence rate of GLP-1 therapy in practice is low, and that's why it is not that much encouraged ahead of SGLT2 and DPP4 inhibitors. What else? Of course, we have taken care of just glucose till now. We must take care of his lipid levels. We must take care of his blood pressure also. Even if it is marginally elevated, in diabetes patient, our target should be to keep it below 130/80 if possible. If he is a smoker or tobacco chewer, avoiding that is also very important. And if he is overweight, reduction of body weight is also going to be extremely important. So statin, RAS blocker, maybe ACE inhibitor or ARB, smoking cessation, weight reduction. How about aspirin? Well, previously, aspirin was considered gold standard for cardiovascular disease prevention. But of late, the trials for primary prevention have shown that aspirin may have a doubtful role in primary prevention of cardiovascular disease. For secondary prevention, that means if patient is already having cardiovascular disease, there is no doubt that we have to give aspirin along with statin. But if patient does not have cardiovascular disease and is not having significant cardiovascular risk factors, then primary preventive role of aspirin is right now debated. So I would mean to say that we need a comprehensive control, and for that we have designed this blue index, which comprises of 10 parameters. It is going to represent the overall health of the diabetes patient, not just the glucose control. So there are 10 parameters in that. A is A1C, B is blood pressure, C is cholesterol, D is diet, and in diet we should take care of the calorie content, the carbohydrate content, and the meal pattern and the irregularities of the meal. E is exercise, where aerobic, weight resistance exercise, and the work-related activity, all this should be taken care of. F is follow-up. If patient is not following up with the doctor regularly, he is likely to miss his goal, he is likely to have uncontrolled hypertension, and that may lead to complications. So follow-up is also extremely important. In addition to that, the general health of diabetes patient depends on his overall happiness, his mental status, and whether he is having obesity or not, whether he is having obstructive sleep apnea or not, and how good is his liver, because in diabetic patient, there is significantly increased risk of non-alcoholic or metabolic associated fatty liver disease. H is habits, that is avoidance of habits, including smoking, tobacco, and alcohol if it is a habit. I is infection prevention. And never in the past, infection prevention had been so important before this COVID era. We know that uncontrolled diabetic patients are at more risk of developing COVID as well as COVID-related complications, and that should be taken care of. So infection prevention is also a very important strategy in diabetes treatment. And finally, J, the jeopardy of diabetes management, which means whatever drugs we may be giving may be having some side effects. So explaining and taking care of them, identifying them very early are the keys to avoid the side effects of diabetes management. And finally, the K, the complications of diabetes must be prevented, and if complications are detected, that progression should be prevented and the complications should be treated in time. We know the chronic complications. I'll not discuss the acute complications, but the chronic complications, are macro or cardiovascular complications, including the cerebrovascular, coronary artery disease and heart failure, and peripheral arterial disease. The microvascular complications include the kidney, that is diabetic nephropathy, nerves, that is diabetic neuropathy, and eyes, that is diabetic retinopathy. So this should also be identified early, prevented, and treated early. And finally, the food complications are also extremely important in diabetes. And food complications are a result of micro, macro, bone-related problem, infections, skin-related changes, everything. So it's altogether a different thing. So having discussed this case, if there are any questions, we'll discuss them at the end. And now I'll just run through some 2 or 3 important cases, which are also very common in our day-to-day diabetes practice. This is a case of a 35-year-old gentleman. He is newly detected to have diabetes and has come to you with 360 blood sugar fasting, 380 ppbs, HbA1c is 11. He has 7 kg of weight loss. His blood pressure is normal. He is not overweight. He is having BMI of 24. Can anyone tell me that what type of diabetes is it and what treatment you will give? I'll give you half a minute. Can anyone type their answer here on the chat? This is the case. Okay. So this patient is having significant insulin deficiency to start with. His fasting is 360. HbA1c is 11. He has significant weight loss. He is not overweight. He is young. So probably this may not be type 2 diabetes. This may be type 1, or this may be latent autoimmune diabetes of adult, or called LADA, which is also a slow type 1 diabetes. So this can be anything, type 1, LADA, or type 2. But at least till we prove that, we should treat him with an agent that will take care of his insulin deficiency. He is insulin deficient at this point of time, and that's why we need to start insulin. Maybe basal therapy or basal bolus therapy. In this therapy, we need to treat him aggressively with premix insulin rather than treating him with oral anti-diabetic agents. So let me see how many of you answered that start with insulin and not with the oral agents. We'll discuss that later. So this patient was started with premix insulin twice a day. Premix insulin, the examples are human mixtard, insulin 3070, Novomix 30, or Humalog Mix 25. These are the examples of premix insulin. After achieving control, insulin was gradually reduced and metformin was started, and currently the patient is on metformin 1000 milligram and sitagliptin 100 milligram. How did this happen? Probably this patient came with glucotoxicity, and once we gave him insulin, his glucotoxicity was reversed, and the beta cells, which had become non-functional, started becoming functional again, started secreting enough insulin, and now patient can be maintained on the oral anti-diabetic therapy with very good HbA1c control. Is this possible? Similar second case, 37-year-old male, 65 kg weight, 10 kg weight loss, and fasting 300, postprandial 500 plus, HbA1c was 12.5 to start with. We started with basal bolus therapy, and after achieving control, he was shifted to premix BID. Currently, this patient is not on any OAD or insulin for the last 10 years, and his HbA1c is remaining around 6. Is this possible? Yes. There have been now several reports, and in our own experience also, of more than 1,500 patients by now, where we have treated with early intensive insulin therapy. It can reverse hyperglycemia. It can reduce the cardiovascular risk in type 2 diabetes. Short-term intensive control. This is a Chinese study, but there are now UK, European, American, as well as Indian studies to support that early insulin therapy in patients with insulin deficiency can restore insulin sensitivity as well as beta cell function. You might be aware about the reversal of diabetes now. The Roy Taylor's theory of reversing diabetes, that if you control diabetes early on aggressively, then in some of the patients, you may be even able to have long-term remission of diabetes. So previously, when anyone came to us, we would say that diabetes can only be controlled. It cannot be reversed. It cannot be cured. But now we know that with aggressive medical as well as diet-related therapy early on in the disease, reversal is also a possibility. Of course, it is not easy, it is not practicable in all the patients, and it is not possible in all the patients, but still, in appropriate candidates, this must be tried. Case. And that is my case number 5. Patient admitted for COVID is detected to have new onset hyperglycemia. And some of you may be managing this type of patients in the wards. If you are attending the wards these days, I'm not sure whether you are allowed to attend the wards or you are just doing the COVID duty outside the hospital, that is in the urban health centers. But anyway, a patient with COVID is detected to have new onset hyperglycemia. How will you manage? Now, the management will be different if patient is critically ill or if patient is not critically ill but in the ward. If patient is critically ill, we need to manage this patient with IV insulin continuous infusion. In a critically ill patient who cannot be relied upon to take enough food or maybe on intravenous therapy, then subcutaneous insulin may not be that much appropriate and effective. So we need to give IV insulin continuous infusion. And usually human short-acting insulin or human actrapid is used for insulin, for infusion in an infusion pump. The dose we have to decide based upon his glucose values and how he follows. Again, because of paucity of time, we will not go into details of that. If patient is not critically ill, admitted in a ward or a room with COVID, then again, basal bolus insulin therapy, which means a short-acting insulin before every meal, that is bolus, and basal insulin, that is a long-acting insulin like glargine, daily once a day, that is called basal bolus therapy. Later on, once the patient is stable and is discharged, if appropriate, he can be shifted to the oral anti-diabetic therapy. These days, we know that COVID patients receive steroids, and because of that also, some of them develop hyperglycemia and they need to be treated at least at that point of time. How do we differentiate that this is new onset hyperglycemia or the patient was already having diabetes and not diagnosed? HbA1c will give you a clue. If HbA1c is less than 6, it would suggest that the patient is newly detected to have diabetes because of either COVID illness or because of the stress hormones that are related due to the stress infection or due to the steroid therapy. But if HbA1c is more than 7 or 7.5, this patient was likely to have diabetes but was not diagnosed. He is now diagnosed since he has come to the hospital and you have checked. Finally, my last slide, case number 6. 90-year-old male, fasting 140, postprandial 200, HbA1c 7.5, very active. All other reports are normal. What are the treatment options? Will you start with monotherapy, combination therapy, insulin, GLP, SGLT2? Well, I'll not give any treatment to him. He has lived for 90 years happily. All other reports are normal. Forget about his treatment, right? But there are very few so lucky people who do not require any treatment. For everyone else, there is a treatment with us so that we can manage them, to help them live long, to prevent their complications, and to give them a very good quality of life. With this, I would end, and my final word for every one of you is stay safe during this COVID era, especially all of you performing COVID duties need to take special care, not only for yourself, but for your parents as well as grandparents if you are staying with them. Thank you very much for your very kind audience. I would stop sharing here, and if there are any questions, I'm here to address them.
It was a great session, sir. We do have a few questions.
Yes.
Also, audience on YouTube live stream can also ask questions. Why do some cases go undetected for a long time? What signs can we look out for to detect cases early on?
Yes, and it's a very good question. Why some patients are not diagnosed in time? Well, diabetes remains asymptomatic for quite some time. Some of the patients may be having diabetes for 5 years and may go unnoticed because in 50% of the diabetes patients, there are no symptoms. The commonest symptom of diabetes is being asymptomatic. The typical symptoms that are explained in the books, like polyuria, polyphagia, polydipsia, fatigue, genital infection, all these occur when there is significant hyperglycemia, maybe in the tune of 250, 300, or when the HbA1c is more than 9 or 10. Patients with 7.58 HbA1c may not have any symptoms, and that is why, unless you test annually after the age of 30 years, diabetes may remain undetected. And even when hyperglycemia is not severe, if not treated, patient can end up into long-term complications like retinopathy, nephropathy, cardiovascular complications. So the message is diagnose early, treat early to prevent complications.
Next question. Why is there requirement in Indian demographics to start with combinations when guidelines say to start with only metformin?
Oh, yes. It's a very good question. So don't write in exams. In exams, you are supposed to write guideline-based answers, right? But in practice, see, previously the guidelines were based upon that start with monotherapy, then step up, then step up. But as I rightly said, that if you start only with one agent, it will take care of one or two pathophysiological factors, right? We are not treating diabetes to see good numbers. We are treating diabetes to prevent complications. So if you want to prevent complications, we should be proactive. We should not be doing a failure-based management. कि अब बढ़ गया, अब treat करते हैं. नहीं, बढ़ने ही मत दो. Don't allow it to increase. And that is the key. And that's why we recommend combination early on rather than delaying the combination. Previously, the guidelines were like this because the second drug you add may cause hypoglycemia, because the previous drugs, the older drugs like sulfonylurea insulin, if started very early, may cause hypoglycemia. And that's why the guidelines were like that. Guidelines will emerge over a period of time, maybe after 2 or 3 years, they will say that start with combination straight away. But guidelines require enough trial evidence. The practice does not require that much evidence. Practice requires evidence, guidelines, as well as the common sense. But having said that, in exams, you are supposed to write guideline-based answers and not what I told in this talk.
Okay, thank you. What is metabolic syndrome and what is its relation with DM?
Metabolic syndrome, as I described, comprises of 5 factors. One is central obesity, waist circumference, more than 19 males or 80-85 in females. Second is dyslipidemia, that is atherogenic dyslipidemia, TG more than 150, HDL less than 35. Third, blood pressure, hypertension, so 140/90 or more. So 4 criteria: TG, HDL, central obesity, hypertension, and the 5th criteria is either impaired fasting glucose or impaired glucose tolerance or diabetes. So if any of these 3 criteria are met, patient is classified to have metabolic syndrome. Why it is important? Because metabolic syndrome patients are at risk of developing diabetes as well as cardiovascular disease.
Thank you. Considering all investigative tests that diagnose DM have been discovered in modern times, is diabetes a modern disease or has it been present all along?
It was present all along. Previously, people used to live only 50 years. And this is a disease not of elderly, but usually type 2 diabetes starts at the age of 40-45. So previously, either it remained undiagnosed, but of late the prevalence has increased because of the lifestyle changes. The life 50 years back was very simple. The requirements were very minimal. एक घर हो गया, घर में ज्यादा से ज्यादा टेलीफोन आ गया, बहुत हो गया. स्कूटर है तो भी बहुत हो गया. आजकल गाड़ी मेरे पास एक है तो पड़ोसी के पास कौन सी है वो देखा जाता है. And all this increases stress. Moreover, the physical activity has gone down significantly. And our diets, our Indian diet was never good. It was a lot of carbohydrates. But now we also eat Indian fast foods. We eat the Western fast foods also. So we have combined, we have taken bad things from them and forgotten good things. So because of all these factors, the prevalence has increased significantly. And it will go on increasing.
Can type 2 diabetes go away if my blood sugar becomes normal? Do I still have diabetes? And do I still have to take the medication?
Yes. It's again a very good question. Can diabetes be reversed? Yes. If a person weighing 90 kg can lose his weight by about 15 kg, in initial years after diagnosis, his diabetes can be reversed. And if you want details about that, you can read Roy Taylor's direct trial, where he had reversal of about 57% of his patients by giving the patients a restricted calorie diet of 800 calories for 3 to 6 months. And he could reverse diabetes by about 85% in some of the patients. That is possible, but it is not easy to achieve. But yes, if patient is taking medicines and if his blood sugar is coming normal, his HbA1c has normalized, then we can say that his diabetes is under control. We cannot say that he has been cured of diabetes. So control is different, cure is different. Cure means no therapy for more than 1 year and still his HbA1c remains below 5.7, that is cure. That is possible, not impossible, but not so easy.
Okay. Can diabetic neuropathy, nephropathy, or retinopathy be reversed with a ketogenic diet? And how, is it proven?
Oh. With ketogenic diet, you cannot reverse nephropathy, neuropathy, and retinopathy. Ketogenic diet will actually do more harm in the long term. For short term, yes. For short term, it may cause good weight loss and can cause some important metabolic improvements. But if patient already has retinopathy, if patient already has neuropathy, there is no evidence that ketogenic diet may improve or reverse that. Actually, there have been reports that it may even worsen that. So ketogenic diets are not generally advisable in long term. There may be short-term benefits, but long-term there may be harms.
Are there any different symptoms of diabetes in men and women?
Gender-specific differences are, well, women probably have more symptoms of any disease compared to men. That is one thing. Second is the genital infections. Genital infections occur more commonly in women, the vaginal candidiasis. In men also, especially when they are non-circumcised, they also experience balanitis. But if patient is circumcised, then the balanitis will not occur generally. Moreover, in males, there may be erectile dysfunction related to uncontrolled diabetes, which is much more common in the, or the rather sexual dysfunction is much more common in the males, and erectile dysfunction obviously is unique for the males only. So these are the only differences. Otherwise, there are no differences in the male and female as far as the symptoms are concerned. Complications-wise, if you ask, cardiovascular complications usually in a non-diabetic patient are more common in male. But if a person is diabetic, diabetes erases their hormonal protection. So if a woman is diabetic, she is no longer protected because of the estrogen from cardiovascular complications. So they compete with males as far as the cardiovascular complications are concerned. In a non-diabetic, cardiovascular complications are much more in males compared to females. But in diabetes, it is equal.
If I'm at high risk of getting diabetes, how often should I be getting checked, and starting from which age?
Yes. For Indians or Asians, because we are in the high risk category, after the age of 30, ideally one should get the blood glucose test every 3 years according to the guidelines, but according to the Indian consensus, every 1 year. But if you look at the American Diabetes Association consensus, every 3 years. Why 3 years? Because even if you detect 2 years later, you may not have developed advanced complications. But having said that, in Indian patients, it is better to have diabetes testing done at least once in a year after the age of 30, especially if you are having family history or you are having obesity or having any of the other features of metabolic syndrome like central obesity or hypertension or anything like that. So once in a year after age of 30.
Thank you, sir. That's all the questions that we got. Thank you for the great session and the amazing question answer session as well.
Thank you, Anjali. Thank you, Dhruvam. Thank you, the whole AMCON team. And once again, everyone, take care, stay safe. Good evening and Jai Hind. Goodbye.
Now I would like to introduce the organizing secretary. Of AMCON 2020, Purvi Cholera.
Hello everyone, myself Purvi Cholera, and it is my privilege to get a chance to say something after all such wonderful speeches. I would just like to thank everyone who has been associated with this conference since the beginning and has been given every minute effort to make this possible today. I would also like to thank I would also like to thank all the professors, our respected dean sirs, the members of our scientific committee, and the judges who gave their valuable time to us, for guiding us throughout the conference, and for making it possible in this pandemic times. I would also like to thank each and every one of you. I know this was not the AMCON we dreamt of in March, but this was possibly the best we could do, and it makes my heart fill with immense pleasure that we could do this and we finally did this. Lastly, wishing everyone all the very best for the upcoming exams, and I hope you had amazing time organizing this, had all the fun, made many memories and a lot new friendships. Thank you.
Unfortunately, we couldn't see all your faces in March 2020 because of the pandemic. We hope you enjoyed our online edition of AMCON 2020 right from your own homes. Thank you to all the participants and the keynote speakers for making this event successful. I would also like to thank my colleagues and my seniors for all the hard work and the perseverance, without which this wouldn't have been possible. We're very grateful for this opportunity to bring an online edition of the conference according to the new normal. The keynote speeches in the morning and the ones right now were very helpful, and you can watch them again on our YouTube channel. Thank you for joining us today. Hope to see you in person for AMCON 2021. Stay happy, healthy, and safe.